Look, it's a pleasure to speak to such a unique and well-informed audience. The breast surgeons involved at various stages in the management of the high-risk individual, both in the risk assessment phase and the risk management phase. So, in both risk assessment and high-risk screening, the treatment of breast cancer in the patient who has a known or a suspected BRCA mutation, and then finally in the actual risk reduction surgery. Well, as the previous speakers have said, the high-risk woman makes up a very small proportion of the overall population. And often the job of the breast surgeon is to assess initially which women are in high, moderate and low risk categories. There are a variety of risk models which we've heard previously. The one I tend to use in the office is the Tyrer-Cuzick one, which gives a probability of there being a BRCA mutation and 10-year and lifetime risks. Once the risks have been estimated, the focus then really shifts to a management strategy which depends on the magnitude of the perceived risk, the risks and effectiveness of possible interventions, and the individual risk tolerance and preferences. So as we've heard earlier, there's early detection, which is basically high-risk screening and surveillance, and prevention strategies, which fall into lifestyle factors, risk-reducing medications, and finally risk-reducing surgery. I'll go through one by one this list of risk-reducing surgery. Why, for whom, if, when, what, how, by whom and where. For those who are wanting a fairly up-to-date sort of, medical review of the literature, this review article in last year's New England Journal of Medicine is a good summary, which is digestible by the layperson of the relatively current evidence. But as both Tess and Heather have alluded to, this is a very rapidly changing field. So why would anyone consider undergoing a potentially radical operation such as risk-reducing mastectomy? Well, I guess the basic reason is that it is the most effective strategy. There are various models looking at the potential risk reduction with bilateral risk-reducing surgery, but most of the studies tend to indicate that risk-reducing mastectomy offers probably at least a 90 to 95% risk reduction in the development of breast cancer. Very few prospective studies, but one of the studies here, the PRO study, looked at 247 risk reduction mastectomies in which there were 0 subsequent cancers versus 98 cancers in the other group of 1,372 women who had no risk reduction mastectomy. The American Society of Surgical Oncology have got a statement on prophylactic risk-reducing mastectomy, and according to their guidelines, from the published data, they estimate that the risk reduction conferred by risk-reducing mastectomy is approaching 100%. It's greatest in healthy, unaffected women with a known genetic predisposition or strong family history. And almost all the new breast cancers in the literature that have been reported in women who've had previous risk-reducing mastectomy are in women in whom there's felt to be significant residual breast tissue for whatever reason, often in the axillary tail, up near the underarm of the breast, commonly is where tissue may remain. Often risk-reducing mastectomy is combined obviously with removal of the ovaries and tubes. Well, for whom? In whom should you be considering risk-reducing mastectomy? Well, like everything else in medicine, the fundamental principle is to do no harm. And we would now tend to offer risk reduction mastectomy rather than recommend it. Women opt for this surgery of their own volition. And all women, I think, who are considering risk reducing surgery in the absence of a cancer diagnosis should ideally receive formal genetic counselling and testing, if appropriate, prior to undergoing this surgery, which is obviously irreversible. Patient needs to, together with the clinician, weigh up the risks and benefits. And to do that, you really need to have a little bit of a grasp of the difference between relative risk and absolute risk. If we say risk-reducing mastectomy reduces your risk by, say, 90-95%, that is really only relevant depending on what your actual risk is yourself. So if you take the general population here, so we've heard from various speakers there's a 1 in 8 lifetime risk, so that's about 12%. If you reduce that by 95%, say, you're not getting a huge absolute reduction. Whereas if you're in the bottom group, with perhaps a 70% lifetime risk, and you're able to reduce that by 95%, you're getting a very significant risk reduction. So the benefit an individual gains from a risk-reducing procedure is directly related to their level of risk. Various organisations have got guidelines as to which women would potentially be suitable. Generally, they fall into several categories. Women with known high susceptibility gene mutations, usually BRCA gene mutations, a compelling family history in the absence of a proven mutation, a variety of histological risk factors, which we've heard about before, particularly probably LCIS, women who've had previous radiotherapy to the chest wall area, delivered at a young age, usually less than 30 or 35, and there are the large group of women who may be at elevated risk and have had a cancer in one breast. And for the purposes of the rest of the discussion today, I think I'll put them to one side because that's a whole discussion in and of itself. I think the key is that it is very much like other areas of breast care, a multidisciplinary approach. That is essential really in the decision making. The other alternatives need to be discussed with the patient, including surveillance and chemo prevention with risk-reducing medications, and the risk-benefit discussion about the fact that the protection is not 100% needs to be pointed out to the patient. The patient selection needs to be individualised, and it should not be a rushed procedure. This is an elective circumstance, and it should be done over a period of time. There are multiple members potentially of the multidisciplinary team, multiple medical specialties and multiple allied health professionals. And central to that is obviously the clinical geneticist. There are certain circumstances in which I think you should not agree to do risk-reducing surgery. In circumstances where the individual's risk can't be substantiated, or there's a suspicion there may be a factitious family history, or Munchausen's even, where the patient has undergone genetic testing and the result is imminent, I think you should not proceed with surgery until that result has been clarified. If the surgery does not appear to be the woman's own choice, if the choice of surgery appears to be for reasons other than risk reduction, i.e. cosmetic, in patients who have potentially psychiatric disorders, cancer phobias, etc., where the risk of the surgery is felt to outweigh any benefit because of comorbidities. And the last group, which are probably the largest group, in women who have immovable, unrealistic expectations of the outcome of this surgery, and I'm sure this is something that Dean will talk about himself. So, how does the individual person decide if that is for them? And I guess to look at this, you can look at the factors that commonly drive women to consider risk-reducing surgery. There's a very large difference in the acceptability and uptake of risk-reducing surgery amongst women across the world. More than 50% of women overall rely on screening alone, and even 20 to 30% of women don't even have the recommended regular screening tests. The Australian figures, these are early figures from Heather's group, from 2006. Only 11% of known mutation carriers were undergoing risk reduction mastectomy and 29% having the ovaries out. More recent figures, again local figures, from this 2013 paper, 21% were having risk reducing mastectomy. 38% were having the ovaries removed, both 12%, and a very low percentage choosing risk-reducing medications, less than 3% in a trial situation and less than 1% outside trial situations. What factors tend to affect women's decision? It's a complex, highly personalised decision, and it's dependent on a lot of things, but three main sort of categories of things: the patient's social and personal context and their family history experience. perceived anxiety over cancer risk and the anxiety with the screening interventions, their own family history. Healthcare professionals' recommendations certainly can influence, and the mutation type. This is what we see when we see a pedigree in the clinic, whereas to the patient, obviously, all of those members of the family are close family members, and therefore the decision making is going to be different to the person who has had a close family member with an aggressive cancer, particularly some of the ovarian cancers, and particularly associated with the decision to undergo risk-reducing surgery is the diagnosis of a breast cancer in the mother. Shared decision making certainly leads to much higher levels of patient satisfaction. It is, however, difficult sometimes for us to gauge the patient preferences and avoid being too paternalistic and yet give some direction. Some women do feel, I think, a little bit frustrated when they come to see us that we're not more directive, but it is an elective procedure, and others find the doctor too directive, and so it's quite difficult to get an even keel as to how to advise women in this circumstance. What we do know is an important predictor of regret is the woman having perceived that the physician steered them into the surgery, and so that's why we are particularly careful not to appear to be too directive. The incidence of regret, having said that, after risk reduction mastectomy is very low and is most common in women who are dissatisfied with their cosmetic result or who have suffered complications, and also those who felt they were misinformed about their options previously. Ideally, it is good if women do have easy access to some form of clinical psychology service under this circumstance. It's not assessing psychological suitability for surgery. It is more making sure that women understand all the psychosocial and physical aspects involved in the surgery. Do celebrity practices have an influence? I think they certainly do. The number of Australian women, whether coincidentally or not, aged 20 to 40 who had risk-reducing mastectomy more than doubled from 99 in 2012-13 to 227 in 2013-14. When, meaning kind of what age? Well, the timing of surgery is obviously very heavily dependent on the patient's personal lifestyle with respect to childbearing, breastfeeding, etc. This recent paper, which had quite a few Australian contributors and was published in JAMA last week or the week before, got a lot of international publicity, and it looked at a sort of contemporary group of mutation carriers with respect to risk, and so it would probably be regarded as the best indicator of risk in mutation carriers at the moment. And what they found was the cumulative breast cancer risk to age 80 was 72% for BRCA1, 69% for BRCA2. The breast cancer incidence increased rapidly in early adulthood until 30 to 40 years for BRCA1 and 40 to 50 for BRCA2, and then remained the rest of your life at a fairly similar constant incidence. The breast cancer incidence risk increased with the increasing number of first and second degree relatives, and I think Heather mentioned this earlier in the day, that your risk with a BRCA1 or a BRCA2 abnormality is also influenced by your family history and the exact type of the mutation, of your BRCA1 mutation. These tables, some of them older, are quite useful in guiding patients' decision making as to the timing of surgery with respect to the incidence of cancer over time. This one is from an Australian publication from 2007 looking at BRCA1 carriers and BRCA2 carriers. For the older woman, the risk of breast cancer may be falling, and they therefore may get less benefit, as I said earlier, from risk-reducing mastectomy. If we look at this table here, for example, 19% lifetime risk for a BRCA1 carrier at age 60, which may be still a significant lifetime risk for that woman at age 60, but it's certainly lower than her lifetime risk. And so women do, to a certain degree, outlive some of their risk as they age. There is an online decision tool which can allow women with known mutations to put in personal data, including mutation and interventions, and work out the efficacy of that intervention at a particular age with respect to reducing the risk of the breast cancer or mortality from breast cancer. And the author of that paper gives a very good presentation online there. So finally, to what is done and how. There have been several recent advances in risk-reducing surgery, largely related to the type of mastectomy and the associated reconstruction, which I think have been responsible for an increase, partly the increase in uptake in women. One is the embracing over recent times of nipple-sparing mastectomy in the prophylactic and also therapeutic setting. The introduction of direct-to-implant reconstruction, and the use of some of the meshes, whether they be biological or synthetic. So in terms of the type of mastectomy, a simple mastectomy is where the breast's removed. In all mastectomy, the breast tissue is removed. The different descriptions really refer to how much of the overlying skin envelope is retained. So in all mastectomies, the breast tissue is removed between the breast tissue and the skin, and in order to retain the blood supply to the skin, it is impossible to remove 100% of the breast tissue. So we generally tell patients, or I generally tell patients, that any residual breast tissue after a risk-reducing mastectomy is not going to be at that deep level, on the chest wall. It's likely to be at this superficial layer. So anyone who develops a breast cancer in residual breast tissue after risk-reducing mastectomy, it is likely to be in the superficial skin envelope and therefore easily detectable. With respect to reconstruction, having immediate reconstruction at the time of risk-reducing mastectomy is much more common than having an immediate reconstruction at the time of mastectomy for cancer. Worldwide, 70% of BRCA1 and BRCA2 mutation carriers who undergo risk-reducing mastectomy will have an immediate reconstruction. Now that compares to a very much lower percentage of women who are having a mastectomy for breast cancer. This slide here just shows the different sort of incisions that you would use depending on the sort of mastectomy you're doing. So a simple mastectomy, a large ellipse of skin is taken and the patient is left with a flat chest wall. So there is no immediate reconstruction, and the deliberate aim is to leave the patient as flat as possible. It is not an advantage to spare skin at that time on the basis that it can be used later for a reconstruction, because it all contracts up and it's useless. So if a patient is aiming to have a delayed reconstruction, for example, the aim is to leave them flat at the time with a flat chest wall on which to wear an external prosthesis. A skin-sparing mastectomy can be done through either a circular incision around the nipple or through an elliptical incision, which is either horizontal or vertical. Which of those is chosen depends entirely often on the type of reconstruction that is being done. And down the bottom, we've got nipple-sparing mastectomy, where ostensibly the breast is removed from behind the skin envelope and the whole skin envelope is left intact, including the nipple. So this is a simple mastectomy, and this is the external prosthesis that would be worn. Some patients in increasing numbers are choosing to stay flat after mastectomy. I think with bilateral mastectomy, it needs to be a very carefully considered opinion, because I think depending on your own physical size and shape, it can have a very significant impact on your posture and your overall appearance if you have a bilateral mastectomy and no reconstruction. There are organisations aimed purely at offering support and information for women who decide to stay flat. Staying flat can be sometimes a bad option for women who carry more weight, as it's very difficult to get this is not a patient of mine, but it's very difficult to get the chest wall flat, and the redundant skin around the side, which is not breast tissue, will often remain, and this will this circumstance would be able to be revised surgically, but it's a difficult circumstance. Skin-sparing mastectomy, as I said, by definition spares everything except the actual central breast, the nipple areolar complex, and what incision you use for that depends on the type of reconstruction. If it's to be an implant-based reconstruction, you can't close a circle other than as a straight line, and so you need to turn it into an ellipse to either end up with a horizontal or a vertical incision, as shown here. And then later, nipple areolar reconstruction plus or minus tattooing can be undertaken. In nipple-sparing mastectomy, as I said before, the whole skin envelope is retained and the choice of incision is variable, from the most hidden incision under the breast there to the right incisions you see there. And that's just examples of the various incisions there and there. So with skin-sparing and nipple-sparing mastectomy, invariably there will be an immediate reconstruction of some type at the time, which will either be an implant-based reconstruction or something using your own tissue. And traditionally, implant-based reconstruction involved a two-stage process with an initial tissue expander under the muscle, which was then gradually inflated over time and exchanged for a permanent implant. More recently, partially as a result of availability of mesh devices, many women who are having risk-reducing surgery are having direct-to-implant reconstruction. So this is the tissue expander that would be used, goes in under the muscle generally and is inflated through the skin serially, through the port in the skin, using a magnetic device. And there are now automatic air expanders where the patient can expand using a canister themselves and swapped over for a permanent implant, whether it be smooth or textured. In direct-to-implant reconstruction, there is a mesh device usually put down to support the lower part of the breast and sort of provide a hammock, and that allows then an implant to be placed rather than the need for there to be a tissue expander phase. Now, the main benefit of that is really not necessarily that it's a one-stage procedure. It is more the fact that you avoid the tissue expansion stage. A significant number of women who undergo direct-to-implant reconstruction will require some form of revision or surgery. So the ideal candidate for direct-to-implant reconstruction is someone who's a healthy non-smoker, small to moderate-sized breasts, who's having nipple-sparing mastectomy and desires to be a similar-sized breast. With tissue reconstruction, the skin from the abdomen can be placed there, giving that appearance. Just moving along, the surgical complications with nipple-sparing mastectomy are greater because of problems with the blood supply to the nipple. And you can often get circumstances where the blood supply is less than adequate. To address this, we will often deliberately do a two-stage operation, detaching the nipple from the underlying breast at stage 1, and then going back a couple of weeks later doing the definitive operation. And the aim of that is to allow the blood supply to the nipple to develop to an extent where it's not compromised. Unfortunately, you do end up with circumstances, uncommonly, where skin is lost, and the risk factors for that are smoking being by far the most common, and the others you can see there: obesity, the choice of incision, larger breasts, and large volume implants. The risks of reconstruction are related to many risk factors, but the two important ones for us are smoking and obesity. Smoking is associated with a very high increased risk of complications with all forms of breast surgery, particularly breast reconstruction. The woman with the larger breast, it may still be possible to have an immediate reconstruction of an implant type. Sometimes for that we'll use a skin reduction incision, ending up with that, or something like that. I'll just move quickly over these ones. So just looking back over my own practice over the last couple of years, how things have changed, say, from the 5 years before. That's probably no change. All but one patient was a proven BRCA carrier. All but 2 patients, though, underwent nipple-sparing mastectomy, and 80% of the patients undergoing nipple-sparing mastectomy had a prior delay. All patients having nipple-sparing mastectomy had direct-to-implant reconstruction. Last year's practice, median age 30 years, age 22 to 57, so I think over time, younger women are considering risk-reducing surgery. All patients who underwent risk-reducing surgery in 2016 had immediate reconstruction. These are just 3 examples of patients who've given specific permission. The other pictures are all patients, photographs in the public domain. These are patients of mine who've given specific permission for their photographs to be shown. So this is a pre-op photograph. This is 19 days post-op, nipple-sparing mastectomy done through the inframammary incisions. That's 6 months, 12 months, 18 months pregnant, and 2 years. So withstands a pregnancy quite well. These examples are all direct to implant. Pre-op, 14 days post-op, 15 months. And I mean, keep in mind, these are ideal candidates. They're really young women, small breasts. They're ideal surgical candidates. Same deal again. What about occult malignancy and prophylactic mastectomy? It's very low with MRI screening these days, and to the extent where we would not normally recommend the need for sentinel lymph node biopsy. Preparation, pretty straightforward. Lifetime risk is probably 3 to 5%. I tend to follow people up, not to detect new cancers, but in case there are any new developments in the genetic sphere. So, just finally, quickly, by whom? I think choosing your breast surgeon is an important decision. Most health professionals working in this area, someone else mentioned, are sensitive to all the complex issues. But the breast surgeon is often the first point of contact for the patient with a clinician and acts therefore effectively as the gatekeeper to the rest of the team. So I think it is worth putting some thought into who you're comfortable with. Now, these are just a few things that people may take into account. The sex of the surgeon may be more an issue with younger patients. This Scottish study, these were symptomatic patients. 68% of women had no preference, but all of the women who had a preference preferred a female surgeon, and those preferring a female surgeon were generally younger patients. Just the general style of the surgeon, you need to feel comfortable with the surgeon, and if you're not happy, go and see someone else. This is not an urgent, emergency procedure. This is an elective procedure. So take all the time you need to come to a decision. I think in terms of, relating with the person, some people relate better with a more authority figure. Some people would prefer a more sort of collaborative decision-making process. And it does vary from person to person. A lot of patients don't want to be directed. A lot of patients do want to be directed. The age of the surgeon, it's a fine line between someone who's not experienced enough and someone who's too experienced, shall we say. And I think you do need probably to go to someone who's doing these relatively frequently. This is not something for the occasional operator. I mean, we saw from those figures, there are only 200 done in Australia per year, and yet there are 17,000 breast cancers per year. So not all breast surgeons will do a lot of these surgeries. And therefore, it is probably worthwhile making sure you go to someone who does this sort of surgery a lot. Finally, where you have it done, whether you choose to have your surgery in the private or the public sector will largely depend on your own personal circumstances. And decision-making around that really depends, I guess, on where you are in your life, the choice of doctor, and your time off work versus the expense of the procedure. In terms of resources to look for, there's a lot available. Many books, many organisations. And I'd just like to finish on this statement because, to be honest, this is, I suppose, encapsulates what I think, that screening certainly is a good option for some women, but I think personally it's a disaster every time somebody who has been known to carry a mutation is diagnosed with a breast cancer. And therefore preventive measures, whether they be any of the things we've discussed, are really worth strong consideration.